In hopes of preventing postoperative velopharyngeal insufficiency, we routinely perform partial adenoidectomy. The microresector blade consists of an outer window surrounding an inner hollow rotating blade. It's angled at 40 degrees to allow easy introduction into the nasopharynx. The blade is coupled to the handpiece, which is connected to standard continuous suction. The speed is set at 1500 RPMs in the oscillate mode. The window is directed toward the desired tissue, which will be drawn in by the vacuum, and the rotating blade then shaves the tissue. It's important to note that the blade is protected posteriorly and at its distal tip. This allows for rapid, safe removal of the targeted tissue without damage to surrounding structures. With the shaver off and the blade positioned such that the window is open, the tool may be used to suction clear any secretions or blood from the field. Specimens may be collected for pathologic evaluation by the insertion of a filter sock in the suction canister. Shown here will be the surgeon's view of a partial adenoidectomy performed with a microresector in real time. Tonsillectomy has already been performed, and the large obstructing adenoid pad is visualized. The shaver blade is positioned at the superior extent of the adenoid tissue and activated. The window is positioned over the tissue to be removed. Slight downward pressure may be applied to cleanly separate the adenoid tissue from the prevertebral fascia underneath. A sweeping motion has worked the best for us, and this motion is continued from superior to inferior to the desired stopping point above pos avance ridge. The microresector is especially useful for precisely removing tissue against the tori or from within the choana, as well as controlling the inferior extent of tissue removal. Once the desired tissue has been removed, hemostasis is achieved with a suction electrocautery. The procedure is then completed by using the electrocautery to sculpt the residual adenoid tissue as desired. With this procedure, we usually preserve at least 15 to 20% of the adenoid tissue just above pos avance ridge. In a prospective, non-randomized trial conducted at Ochsner, we found that a partial adenoidectomy performed with a microresector was superior to the procedure performed with curettes. The average total operative time for a partial adenoidectomy performed with a microresector in over 100 patients was 3 minutes 21 seconds. The actual tissue removal was usually completed in under 1 minute, and the majority of time was spent achieving hemostasis. The average operative time for the procedure using curettes was just over 8 minutes. Blood loss was comparable with both techniques. There were no postoperative complications in either group. Besides the obvious advantage of speed, we feel that the most important advantage of the microresector technique is precision. The microresector affords a degree of control over tissue removal that cannot be matched by curettes, and therefore the risk of inadvertent tissue removal is lessened. Although the number of patients in our study was too small to demonstrate a difference in complication rates, we feel that by achieving more precise tissue removal, we can decrease the risk of postoperative velopharyngeal insufficiency.